I think that the background to this is really that we see a lot of reforms, we see a push everywhere towards integrated care and better quality care, and yet the felt experience of patients is often one of difficulty in navigation, fragmentation, quite glaring gaps in the experience of care. So that's what we're really here to discuss and explore. So Alex, do you want to sort of kick off and tell us how's industry, how's the pharma industry adapting? Eli Lilly in particular.
Yep, certainly. So as we think about founding our work on patient centricity, which is a newer thing in the pharmaceutical industry, for us, patient centricity is founded on having a deep, deep understanding of the patient first. And we call that getting to know the patient journey, the continuum of care, all the way from the onset of illness through diagnosis, through treatment, and hopefully through cure, and understanding all the impacts, the behavioral aspects of what's going into the patient care, what the patient is feeling. We in the pharma industry are very fortunate in that we focus in certain numbers, limited numbers of therapeutic areas. That gives us the luxury to really dig in very deeply in ways that, say, a hospital system or provider group or an insurance company can't, because they have the entire universe of care to deal with. So, for instance, with us, whether it's diabetes or oncology or neuroscience, men's health, women's health, areas that we can 5 to 7 years even before launching a product or getting into a therapeutic area, do considerable market research, talking to patients and providers, payers, to get that deep understanding. And what we try to get to is where in the journey that the patient is progressing through do they have those key emotional moments. And those are the moments where they either are going to fall off the treatment path that they and their physician and their payer have decided is the appropriate and right one, or they stay on that. Those are those moments of truth. Then what we focus on is, are there interventions that we can appropriately put to work on those core moments of truth that will help keep the patient on the path, the journey towards wellness. And so what we do then is those interventions, we try to work with our partners, the patient directly. In some instances, we tend not to have a lot of direct contact with the patient when you're on the manufacturer side, but really with our partners who are the partners, the healthcare providers, as well as the hospital institutions and payers, to see if we can develop interventions that can help resolve those moments of truth for the patient. So let me give you an example. One of our more popular interventions is for a patient who's had a stent for ACS-PCI. So they've had a stent procedure. Well, when you really get deep in and understand what's going on for the patient and his or her caregiver, you understand that at the time of discharge, they're still in a fog often. They have just had a massive, possibly life-changing event, and they're getting instructions thrown at them. They're being handed this piece of paper, this piece of paper. They have at least 5 medicines they've been put on. Each of those, if they're lucky, maybe have $10, $15, $25 copays, and as an individual, those might seem fine, but you add them together, 5 to 10 medicines possibly, that adds up. They're thinking about the cost. They're thinking about having to go out and get these. They're getting conflicting instructions. They're still in a bit of a fog and a haze. So when you get to that deep understanding of what's really going on in their life at that moment, when they can fall off, when they cannot take, for instance, one of the critical medicines they need to protect the work of the interventionalist, we've created a video that is used in hospitals now that is unbranded. It's not to try to get you to use our product. It works just as well with anybody's product, that tries to explain to you, what have you just been through? Why do you need to take the medicines that your doctor is telling you to take? The why. We all don't like to do things unless we understand the why. So getting at that kind of intervention. One other one that we have is around women and osteoporosis. Women who suffer an osteoporosis-related fragility fracture. This is a severe fracture coming about from osteoporosis. Only 25% of those women are ever treated for their osteoporosis after that kind of a fracture. 25%. So you've got a massive treatment gap and a transition in care problem. What we try to do then is work with the payers and the providers, even integrated systems, and help pull together the parts of the system to make sure the handoffs happen between the orthopedic surgeon over to the room and endo, perhaps, or the primary care physician, so she doesn't get lost after that procedure. And where does that come into play? That's critical for providers and payers as they think now about core metrics, readmission rates, repeat procedures, for instance. So we try to all partner together to help with this patient-centric approach to improving their care. So then we try to think about how do we connect with our customers and partners in this. So we've really changed our Salesforce approach to be a much more, hopefully, patient-centric and provider-centric approach to how we talk to physicians, as opposed to the old more, here's a message about a product. Instead, what do you need from us? What do you need by way of information, education, materials, et cetera? Can we provide that? We've tried to, with our payers, really build up our real-world evidence health outcomes foundation to get them the data that they need to make decisions. And then for our integrated systems, we have a pilot going now that's fairly novel, where we've carved out 6 areas in the country, including here in Massachusetts. And instead of having just multiple sales forces, the entire state of Massachusetts is one organization under single leadership with dedicated medical resources. Everybody who's touching partners, for instance, or Mass General, are all working together so they have a single point of contact, so that we can integrate our work together, really calling on the D-suite and C-suite, and figuring out how do we fit into your practice? How do we help you help our patients together? So those are that's the core of what we're trying to do when we talk about patient centricity now.
And as president of Lilly USA, I mean, thinking back to the last debate, has the ACA had an impact? Are there specific examples? Has it facilitated this, and in what ways?
So it has had an impact, although the thing that everybody, myself included, was looking for coming out of the ACA was around the exchanges. That was the sexy thing that everybody was focused on, was the insurance reforms. To be honest, I've not seen an impact as I look at our utilization. I've not seen impacts on utilization yet. It's a bit early, but coming out of the ACA, it's unclear where the life's coming from. Were they really previously uninsured? Were they previously insured? I'm not seeing that yet. I'm paying the taxes for it. We've been writing the checks for the last couple of years. Where I've seen the impact, and Anne will certainly be able to talk about this, were the provisions people didn't talk about. The quality and payment provisions that were in the Affordable Care Act currently put about 3% of reimbursement at risk, and by, I think, 2017, it puts as much as 8% between meaningful use of IT, hospital readmit rates, hospital-acquired infections, and a couple other provisions. On a relatively low-margin business, a lot of theirs is being put at risk. So I have seen a focus now, not just at the C and D suite level, but at the provider level, the interventional cardiologist level, saying, I need to know about 30-day readmits. That matters. That's critical to our operating model. So I've seen a radical transformation, and those changes have led to an aggregation. 2008, 30% of physicians were owned by institutions. Now it's 60%. I mean, very swift, rapid change from various changes in reimbursement, IT requirements, bureaucracy, some changing demographics about who's going into the practice of medicine. So that part, the provider side, has been swifter than I think anyone predicted.
And Anne, what's your take on that? I mean, I know you, as Chief Academic Officer, you have a great interest in research and putting patients at the center of research.
Absolutely. So I think it's a way of recrafting, if you will, what we mean when we say the patient journey and how that really relates to a number of different things. So I really wanted to talk about it a little bit in terms of what that means in the journey that you already talked about, how that relates to things that are going on at Partners Healthcare. But one of the things I really wanted to focus on is what this means as having patients be partners in innovation. How do we engage patients? Because patient-centered clinical work also means patient-centered innovation. How do we bring patients in? What are we doing at a local level? What are we doing at a national level? And what should we be doing to coordinate all these things? And then finally, what are the technological advantages and advances that actually makes this possible? So in terms of the healthcare system, you've really laid out nicely what the challenges are for the system, for the patients, for the providers. And I would say that this continuity, and again, this goes to the technology, has been very much enabled from the patient point of view and the provider point of view by the use of the electronic medical record. and in bringing together patients and physicians as partners in really understanding what it is about continuity of care that works, that doesn't work. These things about prescriptions that are written but never filled. These things about patient handoffs. What does it mean when a patient goes into a hospital and then goes out into a community hospital or goes into a rehabilitation center? Who's tracking all this? Who's monitoring all this? So these are things that, many years ago were almost impossible. They were doable, but they were doable in a very small way. And what we have with an electronic medical record is an ability to integrate all these things and see them across thousands and hundreds and thousands and more of lives, and actually try and do predictive modeling. And this gets into what we do with the data, which is sort of another interesting topic, but very much related to it. How do we make those connections, and how do we learn from it? The research part of it is what I really want to emphasize, because if I have to think about ways in which the government and academic health centers and industry, how we all work together in terms of this, it really does come to patients. So how are we doing that? And I would say that a couple of things. First of all, patients have always been, in many ways, the passive recipients of care. They've been the passive recipients of innovation. We talk about drugs, we tailor drugs. The example you gave, a beautiful example. As an endocrinologist, it definitely resonates with me. The patient with the fracture, who gets treated, who doesn't. But who is it that asks those questions of patients as to what it is that matters to them? And I think that this is a new change for us, is actually engaging patients in understanding what our research endpoints are and engaging them in the economics of the entire model. And how do we do this locally? Well, one thing is by the creation, and again, I'm sure most of you or many of you have heard this, of a patient portal. You have a patient portal, a patient can directly get into their chart. They can speak to providers through this. They can see their data. They become engaged in it. How does research relate to this? Well, we're doing the same thing at Partners Healthcare. There's a way now in which through the medical record, you can actually get tagged, or you will be able to get tagged for studies that may be of interest to you, things that you may care about. You can sign up for things. This is an advantage. It enables the patient to be part of the research process in a very important way. Nationally, what's happening? PCORI, Patient-Centered Outcome Research Institute, a large federal effort. They're asking something that's never been asked before in a systematic way. What do you care about patients? What do patients care about in terms of disease endpoints? Maybe it's fractures, maybe it's pain, maybe it's things that we don't think about in chronic disease management. They are asking for and funding proposals that actually have patients help design the research. Again, a big step forward. So engaging patients in this whole process, I think, is a very important point I want to make. Engaging them in innovation, having them not only be the center of coordinated care, but also have a voice in research and how it's crafted going forward, and the kinds of innovations that come out in therapeutics and devices that actually speak to their issues. And then I would also just make a point about the technologic advantages and advances that we have out there that are enabling us. And I hope when we get back into this discussion, we can talk about how we all can do this in a coordinated way, because that's what the academic health centers are doing. What's going on in these other areas that can help integrate that into a totally different and hopefully better model.
Sam, your turn, payer perspectives on this.
First of all, thank you for the opportunity from The Economist to be here with all of you today. It's terrific to be with Alex and Ann. Our careers have intersected over the last decades, so that's all wonderful. I also want to thank so many of the speakers earlier today who said such gracious and engaging things about health plans and health insurance companies. I probably should thank the tobacco industry for giving us loft also. But that said, our focus is really about consumers. And we live in a number of ages. We live in a technology age. We live in an information age. We live in an age of biology. In fact, as we sequence our genomes, it is going to be profoundly changing of how we anticipate care, how we look at health, and how we look at healthcare. But the one age that is truly going to make a profound difference is this age of consumerism, because I heard lots today about all that is is broken in our healthcare system, and certainly we have a healthcare system that costs more than any other in the world, that doesn't deliver the quality outcomes as many in the world. However, I am so optimistic about many of the initiatives and programs and activities that we all have underway that are going to make a difference. So let's ask ourselves, what do consumers / patients, what do individuals want from a healthcare system? And I think that's important. And I'm going to just quickly touch on 5 areas and give an example of each that we're involved in. In many instances, we're involved across industries, but the focus is we're all winners when individuals are engaged in their health and engaged in their health care and engaged in understanding an illness if it occurs, because they have so many opportunities to change that course of illness. I think that one of the first starting points is to recognize that we are our genetics, and we can't change those very much today. We are our environment and social factors in our health, and that the actual care that we receive by doctors, by breathtaking technology, by drugs, accounts probably for 20% of our overall health. So that's a starting point. So we have to be mindful of that as we approach the problems. So what do people want? They want, number one, information to be engaged. They absolutely want a personalization of care that is going on at academic centers, at great pharmaceutical companies like Lilly, and across the world. So I know we talked about big, and I won't use the data word, but big information, big knowledge. And so here's where we're involved with IBM on cognitive computing. The idea of supercomputing and teaching a computer to think like a health professional, like a clinician. So that information, none of us can keep up with this growth of information, but that information can be used to improve care. Many people wouldn't necessarily know, but we have at WellPoint a subsidiary company called HealthCore. HealthCore works with academic partners, with pharmaceutical companies and others to understand what happens in the real world after a drug or device is approved by the FDA. How do consumers use it? Second theme, safety, quality, and outcomes. This is an area that we really all have to work on together. And we look at this, part of it is transparency, understanding outcomes from different hospitals and institutions, because that's the way, by shining light, we're going to see how we can reduce the variation and improve. A recent example that we were involved in is called California Patient Safety First. And by shining light and working with hospitals and doctors, we were able to reduce hospital-acquired infections by 60 to 70%, elective labor and delivery that was premature by 74%. This is what will make our healthcare system better. And also, we're working on a sentinel system with the FDA for drugs after they've been approved, and with CDC on vaccines. So how do we use information and engagement to make a difference? The last 3 areas I will go through quickly, because I know when we have our discussion, we'll touch on them. They've already been touched on. But coordination of care. And that requires payment innovation. It requires delivery system restructuring. Because in our commercial population, by the way, WellPoint, soon to be renamed Anthem, is, we believe, the largest health plan in America. We cover about 37 million Americans. We touch about 72 million through our subsidiary companies, largest in Medicaid, largest in commercial, largest on exchanges, and across the United States. So we really, in very many ways, see it through a series of lenses, but care coordination is essential. 1% of our commercial population accounts for 28% of all care. 5% is 57. There are opportunities in how we use specialty pharmaceuticals more wisely, how we use care management more wisely, how we have experimented along with others with medical homes and ACOs. And these programs are beginning to get results. Our medical home programs, and this is published in Health Affairs, so you can all read this should you wish, but have actually lowered the cost of care and have improved outcomes, as have been our ACO programs. Access is number 4. Consumers want access. Now, I know access means many things to people. I think to traditional hospitals and physicians, it means getting an appointment. But there's a new form of access, retail clinics. If we go to CVS, CVS Health, one of the sponsors, and look at their whole minute clinic system. And many other retail clinics are out there because we, as a delivery system, physicians and health professionals, haven't offered the access and convenience that is necessary. But it goes beyond that. If you think of what people want, we've surveyed 70% want physicians and their care professionals to use social media. They want to be in e-contact. Some of you may know a Boston-based company, American Well. We've been investors in it, and we offer what's called Live Health Online today, where any one of you could go online for urgent care, select the doctor of your choice, seeing their backgrounds, and 24/7 in 43 states, because we have regulation in others, you can actually get care. And let me close with affordability and value, because most of all, we want a health system that does deliver affordability and value. Now, affordability is a challenge, and some of us have seen recently with the advent of new drugs for hepatitis C that that's challenged. Here we have a drug that has made it through the breakthrough therapy process. Yep. It's a spectacular drug. It cures the vast majority of people. Yet as a nation, this is the first time we're asking, can we afford it? Can we afford an average cost of treatment, at least for the thousands of people that have been treated in our organization, that runs about $135,000, $130,000. Can we afford it? Can Medicaid programs afford it? At the same time, continue to build infrastructure. And exchanges, we've seen, and I'll close with this, that we've seen that when people were given choices on exchange, they were shopping largely on price. That's why they bought bronze and silver programs, mostly. 85% of people were still being subsidized on exchanges, but affordability rules, and we have to demonstrate as a health system, and I know pharmaceutical companies are working on this, delivery systems are working on this, what is truly of value in the eyes of the consumer. So in closing on this comment, I think that we have to be innovative, we have to take waste out, we have to leave that headroom for innovation, and ultimately, we have to, amongst all of us, develop a shared accountability for our health and a shared accountability for managing important illness. Thank you.
Thanks, sir. I have some questions, but I'm not going to ask them because I think there may be lots in the audience, and we only have till well, another 20 minutes or so. So can we move straight to you guys? Yeah, please. Is there a mic? Oh, thank you.
Great comments, Dr. Nussbaum. I've been in the field of genomics for a long time and still waiting for the day when that's going to really impact our health and help us figure out what our trajectory towards disease is. So actually I have a question for Dr. Nussbaum, but also would like to hear from the other panelists. We talk about patient engagement, but what about, I want to redefine what my doctor does. My doctor at the moment has potentially no clue as to what matters to me when it comes to my health. And I'd say my number one priority now, because 3 years ago, I ended up in the hospital with a pulmonary embolism, is to never have an event like that happen to me again. I'm 42 years old, and I don't want to see another hospital under those conditions for the next 30 years. And I know my doctor isn't thinking about that. So what are we going to do to change that?
Think of this as care teams. And who's the center of a care team is actually the individual being cared for. And because as you become more and deeply knowledgeable about the consequences of behaviors, how you can promote health, ultimately what may be genetic considerations, that's when you and your physicians and nurse caregivers and pharmacists and a whole team will be assembled. In fact, we've tested this model, and there are others that are being tested on care coordination, so a little bit different than your question, and that's when the results are the most spectacular. That's when people can stay at home and get better outcomes of care. And we have to do more of that on the wellness and health side, as we have been able to do it increasingly on the chronic care illness side.
So you raised two really important points. I mean, the first one in thinking about genetics and genomics and its impact on individual health, and what can any of this tell you as a patient? I mean, this is a very important concept that we've talked a lot about. So at Partners Personalized Medicine, we have invested in a Partners Biobank, and the goal of this is to get and is getting DNA from ultimately all its patients, but the key thing is to link it to very specific phenotyping information, imaging, and all the other parts of healthcare, all the other information that will be useful in the future. I think those kind of predictive models hold a lot of promise. they're not there yet, but that is clearly an important thing. The second point you raise is one that I wanted to raise in brief with the PCORI initiative. It's really to the heart of that question. Physicians are caring about their own endpoints. What does the chest x-ray look like? What are the risk factors in the family? And the 5,000 other things. And when you sit there as a physician, because I do this as a physician with my own patients, you have 30 minutes. And by the time you actually get to the things that patients want to talk about, you don't have a lot of time. And this is the reality of it. So what do you do about that? Well, one thing is, again, to engage patients in asking the questions. So I posed it in terms of involving patients in the research questions, but it really is part of the same continuum, is what patients care about, and how do you get that information given the brevity of the visits now, which are not going to get any longer. So part of this is using online communication. We've created online education, community portals for patients, because these are the kind of ways in which you can gather together, perhaps with other people who've had pulmonary emboli, or other people who are thinking about the questions. You have, and you know the question that you have on your mind. My worry always are all the patients out there who aren't quite clear what their question is. They just know something's missing, and they want an opportunity to hear it. So I think you have to do all of that to get any closer to the things you're raising.
About 7 years ago when I joined Lilly, I was out, back to the previous point Ann had made, about we need to look at it from the patient's perspective.
Yeah.
I was out in Southern California in Long Beach at a very well-regarded community mental health facility. And there was a doctor was recounting his interaction with one of his patients, where the patient said, you know, you think in terms of symptoms. So that's what you're looking for in a cure. That's not what I'm looking for. For me, as a schizophrenic, he said, I don't really care if I'm hearing voices. What I care about is, can I hold a job? Can I get and keep an apartment and not live under a bridge? Can I actually have a date? That those are the, that's the symptomology for him of cure, not DSM characteristics. And we've all, in this space, got to get better at, including our regulator, at looking back at what does the patient need by way of outcomes.
How does that play into your kind of R&D cycles in the future? That kind of...
It's quite difficult because, especially in established pathways, you're dealing with criteria the FDA has laid out as the appropriate clinical criteria that we've got to do we've got to provide 2 randomized phase 3 clinical trials to get approval on against those endpoints. And certainly patient-reported outcome is not going to get you there, and for the most part. So it's tough for us in this framework because it's sort of a double. We've got to hit it on the symptomology, the classic symptomology, but then from a sales and marketing perspective, you have to try to figure out, and obviously only in appropriate ethical ways, are there ways that you actually are connecting to what the patient does care about in addition.
So, and I think that speaks to our challenge of a higher integrative function, if you will, okay, of what patients are thinking, of what the FDA wants, of what you need to provide, of what we can do with our patients. And that model's not in place. They're at very different points right now in evolution. I think it's a moving target. It's just a moving target in different ways at different paces. And I think to your point also, both said and unsaid, unless you can engage the FDA and engage regulators in this discussion, it is yelling in the woods because you're not going to get very far. And I think that's something we need to confront.
You know, and while Ann and Alex are speaking about discovery, so new therapies, when we have existing therapies, there is an opportunity to advance knowledge. I mentioned earlier the work we all do together on real-world research. But another approach is that we, as health plans, when there is evidence, support off-label use of medications. So as we understand more and more about the biology of cancer and the many different cancers, we should, and a number of us are working with Brookings and others, should be able to try to get the information together so that we have outcomes research experiments that are taking place after a drug is released and after it's used for various types of cancer. And that's, again, an example where you're not going to be studying that in a RCT, but we, together, with the right information, can actually advance patient care by seeing what the impact is in certain cancers, particularly those that have molecular homogeneity.
I just
One more
want
comment,
to
and then we'll
just to add in terms of this data issue, because I think it's so much at the heart of this. I mean, at Partners, we have this RPDR. It's a research patient data registry, which enables you to query hundreds of thousands of charts to get information. That's something companies want. And that's something you could say, well, there's a healthcare system doing it for their healthcare system, partnering with others, that's great. But to my mind, this could go on all across many, many, many healthcare systems. And if you could get that all together, that would be a much more advanced thing. And the reason I'm mentioning this is because it brings in regulatory burden and HIPAA and many other things that really govern data that have to be taken seriously. And somehow we have to work through them to get to where we want to go, because there are fundamental truths in those regulations that we don't want to change. But there are also things that we need to work on together, I think, to get to where we want to be.
Paula Buick, nurse and healthcare planner. I'm just would like to know what you're thinking and what you're planning as part of this patient-centric world that we're going to live in for my psychological, behavioral, and mental health. As Sam mentioned, there's only a percentage of our healthcare is related to actually what my physician tells me how often to take my blood pressure medicine. So just wondering what your thoughts are on that.
So you're talking about psychological and mental health specifically, or are you talking about things that go beyond what you might call conventional sort of acute care services, or are you talking about preventative and public health measures?
Yes, the overall power, the population, us who have psychological, behavioral,
Right.
and mental health. What sort of efforts are?
Yeah.
I mean, just to start out, there's often a divide between those physicians or healthcare providers who care for patients and their quote-unquote medical problems versus those that will take care of patients in terms of psychologic or psychiatric problems. So in many ways, one could say that's a terrible divide that took place many years ago, and that there is a return, or should be a return, to an integrated model of patient care, which doesn't view these things as separate phenomena, but views them all as part of the patient's health care. One of the ways in thinking about that has been to embed those clinicians who have expertise in these areas into a clinical team, okay, in a clinical setting. So it's really kind of a multidisciplinary, if you will, approach where you have people with different levels of expertise, including people who are going to be informed, educated, attuned to, and knowledgeable in those psychologic/psychiatric problems, diseases, issues that come up that have such an impact on health. So I would just summarize it by saying it's the right way to go, and this is what we're aiming toward, is to integrate all care and not have them be viewed as separate models.
Well, and certainly from a pharmacologic perspective, when we're dealing with mental health, an area that Lily has really pioneered for decades in, we lack the markers.
Yeah.
I mean, that's there's so much alchemy in the practice of medicine still there that this is why we work with our payer partners, and we've always had tremendous success working together on that, and with the mental health advocacy community, to really have the provider in the driver's seat with the patient there, that to maximize choice, that they can try the different elements in their armamentarium. That's been a major point historically for us for decades of trying to work to protect the centrality of the patient-physician relationship around mental health, because it's not as if we can just run a blood test and figure out this drug works, this one doesn't, for instance.
Yep.
So much, as my colleagues have said, team-based care, community-based care, new biology. In fact, some of you may have seen them just last week, I think, the American Journal of Psychiatry looked at schizophrenia. So now we're talking about one sort of clinical diagnostic group, but what they found is they looked at the molecular genetics. They sort of clustered into about a handful of very specific clinical attributes, clinical symptoms, clinical issues. And that's going to enable the fundamental research and the drug discovery to proceed at a very different pace. So again, doesn't preclude all of the good work in biology to only talk about that, but there, as you and others know, there are community resources. It's not only behavioral health professionals that can do this, and that's including groups that share a common ground, yes.
I would just add that to your point about the biomarkers, how really important that is, because innovation, therapeutics, et cetera, will go where that is. It has to. But this question of psychiatric disease and its diagnosis is a major one. And the Bible, the Diagnostic and Statistical Manual, has come under question by no less an authority than the head of the National Institute of Mental Health. And basically, I think the positioning is bring us an integrated model of these symptoms that go well beyond the symptoms, but actually get to the biology of many of these disorders in a way that is biologically based, and therefore one would expect, hope, lead to the kinds of markers that will develop treatments. But that, I think, is an important but separate issue from how we integrate, to your first point, these things together in taking care of patients.
Does that answer your question? Yeah. Okay, good. Okay, yes, over there.
There's lots about genetics now. Innovations, the pharmaceuticals are eager to get all the data. We as hospitals can start gathering data, but we have to be very, very careful, because I think that the ethical issues are not straightforward. I think that there is still a gap between what our technologies, our technology abilities are, and where we are ethically. And what do you think of it?
We've got a couple minutes left, so I think we'll keep the responses brief, if that's all right. Yep.
I think you've just articulated the very concepts that I think we all can embrace, which is these are critical things, and they need to be worked on together. I don't think you've said anything that isn't completely aligned with everything that needs to be worked on in the future going forward. They do need to catch up, and it's a question of how quickly they catch up and how we can do it together.
Well, and unfortunately, government regulation tends to be a day late, dollar short generally. And so HIPAA high-tech is regulating a technology world that was decades ago, and we're trying to work together to collaborate to bring real cutting edge. I will not use the big D word, but there is so much potential there. But the regulatory frameworks do actually get in the way of collaboration and advances, and we need to figure out a much more agile regulatory framework that protects the ethical issues you're talking about around patient privacy and consent, but it's not where it needs to be.
And on a positive note, we have the Genetic Information Non-Disclosure Act, which can establish bias. That's terrific. And from health plans, if we are actually engaging to facilitate care, to coordinate care, to make care better, to fill gaps in care, particularly pharmaceutical gaps, we can use identified data, and we can engage through nurse clinicians and others. So that's one of the advantages that the laws do allow. So yes, your theme is right, but there are some bright spots and more we need to come forward with.